A very good evening to everyone. It is a pleasure to interact and host and be together for this session on posterolateral corners. We have two eminent panelists, Dr. Roshan Wade and Dr. Nagaraj Shetty. On the other hand, we thank Dr. Ashish and Secretary Dr. Vinay Pandey from the Arthroscopic Association of UP for launching this and taking us ahead along with the Varanasi Orthopedic Association. We give a special thanks to Ortho TV, Dr. Ashok Shyam for hosting us and for taking us into the online digital platform as ever as he has done during the COVID pandemic. And our three faculties speakers for the evening are Dr. Sitab Rai, Dr. Amit Kumar Jha, and Dr. Neeraj Srivastava. I hand over to Dr. Vinay Pandey to take onwards, the Secretary of the AAUP. Dr. Vinay, please.
Thank you, Dr. Karmaraj. So we are very lucky to have this. Without wasting too much of time, we should straight away go with the presentations. The first presentation is by Dr. Amit Jha regarding PLC management and the recent updates about it. Amit, are you ready for this, for the presentation?
Yeah.
Okay, over to Dr. Amit.
Is my slide is visible?
Yeah,
Yes.
Good evening, everyone. Myself, Dr. Amit, is going to present topic on PLC management and recent update. Big thanks to AUP and BOA team for giving me this opportunity. So posterolateral corner, once it was considered as the dark side of the knee. In 1983, the incidence, as reported by Delhi et al., was around 4 to 5%. But over the years, as we increasing the knowledge of posterolateral corner anatomy over the decades, what we found the incidence at present is around 30%. Most of this injury are associated with ACL and PCL injury. Only 28% of this injury is in isolation. So what happens if you fail to address this injury? It altered the knee biomechanics and leading to the failure of the other cruciate ligament reconstructed, and ultimately it's led to early degenerative changes of the joint. So looking back into the anatomy, at 1976, Dr. Houston has first described this posterolateral corner, lateral compartment, and he has divided the lateral part of the knee into anterior third, middle third, and posterior third, and still we were not that sure which part to reconstruct and how to reconstruct. C. Baker described this lateral anatomy into different layers. Superficial layer 1, which consists of ITB biceps femoris, layer 2 with retinaculum, and in the layer 3, coronary ligament and the popliteus tendon. In the late 1990, Dr. Robert Loperard, who has done a wonderful job in this posterolateral corner injury, and he described that there are three major static stabilizer of the PLC are the fibular collateral ligament, popliteus tendon, and popliteofibular ligament. However, the secondary stabilizer, we should not forget, is the lateral capsule, ITB, biceps femoris, and fibulofibular ligament. The fibular collateral ligament is the primary varus stabilizer, which attaches around 1.4 millimeter posterior to the lateral epicondyl and distally at the tibial head, which is around 28 millimeter distal to the tip of styloid and 8.2 millimeter posterior. Popliteus tendon attach in the popliteus sulcus, and average distance between the FCL footprint to this is around 18.5 millimeter, and at the average length of the tendon is around 54 millimeter. Popliteofibular ligament is attaches at the posteromedial aspect of the fibula, and it has a two arm which embraces the popliteus tendon. So this is the one amputated limb video where what we see, this is the biceps femoris, and it's not the isolated static structure that they have not connection with each other. What we found in the dissection that every structure is interconnected with each other, and there is not separate demarcation between this. As here we see the biceps femoris and LCL is this thing. The relationship of the popliteus tendon changes with the flexion angle, and it is attached to the anterior part of the sulcus. So biomechanics, we have to consider three things. One is the varus, second is the tibial external rotation, and third is the internal rotation. So primary distant to varus is the FCL, and the secondary are the other structure, while FCL and popliteus complex between 30 to 40 degree act as a tibial external rotation restraint, while PCL act as a secondary restraint at higher degree at around 90 degree. And PLT play minor primary stabilizer of internal rotation. In the case of ACL with PLC injury, it is important because the PLT is the structure which prevent internal rotation. Well, PCL, a section of the PCL produce more posterior tibial translation at an angle of 90 degree. However, PLC is the main primary restraint to posterior tibial translation at near full knee extension. So this biomechanical study gives us the idea regarding the posterolateral corner. The mechanism of injury: direct hit to the proximal tibia, hyperextension and varus force injury, lateral dislocation of the knee. These are the injury where we get the posterolateral corner injury. So diagnosis suspicion is the must. On history, in acute stage, usually we present with the pain over the posterolateral side with ecchymosis, swelling, and the main instability is in extension and uneven surface walking while climbing down a stair and walking uphill. They give instability symptoms. On careful examination, we get a good posterior subluxation. In chronic cases, they usually give a varus alignment, and when they walk with the varus thrust. So this is the example of a neglected posterolateral corner injury. So what we are saying, the knee not only going into varus thrust but also in hyperextension. So clinically, there are few things we have to perform. One is the varus stress test. So at 30 degree and 0 degree, which gives the idea about the FCL status. If at 30 degree, there is increase in laxity compared to the opposite side, there is injury to the FCL and potentially secondary stabilizer. But if this stability is restored at full extension, then isolated injury to the FCL is presumed. While varus instability, if persists in full extension, then FCL, PLC, and combined cruciate ligament injury is suspected. We have to perform the dial test at 30 degree and 90 degree. If at 30 degree it is more external rotation compared to the contralateral knee, then it is PLC injury. If it is more at 90 degree, then it is both PLC and PCL injury. Reverse pivot steps, they give a good idea regarding the PLC injury. However, there is false positive rate up to 35% of this test. External rotation recarbatum test is very useful, but only 10% of this injury, this test is positive, and this test is more predictive in case of combined ACL with PLC injury. So in investigation, the first is what we find in our plain X-ray is the lateral joint space widening. Sometimes we find the avulsion of the tibial metaphyseal part or fibular avulsion. In chronic cases, we have to take the scanogram. So stress radiography has a role as described by Labrade. If it is more than 4 millimeter varus stress opening, the complete posterolateral injury is suspected. If in PCL stress radiograph it is more than 12 millimeter, then combined PCL with PLC injury is suspected. MRI reconstructed coronal oblique detubated image should be sought for because this gives a good idea about the PLC structure. If it is taken within 12 weeks, if it is taken more after 12 weeks, most of the injury are missed. Only 26% of the injury can be diagnosed after 12 weeks in MRI. So clinical diagnosis is main. When you come to the treatment part, the questions which comes to our mind is when to repair. Does any classification system guide us which structure to repair? Conservative versus operative, repair versus reconstruction, which technique, open versus arthroscopic, and what is the rehabilitation should be done in this cases. So this is the consensus statement published in knee journal, and where the 27 experts in this from the 21 different countries, they have given their statement regarding the diagnosis, classification, treatment, and rehabilitation system. So when to operate? Usually acute treatment within 3 weeks, it gives a good outcome. However, treatment after 3 weeks and chronic injury gives a similar outcome. And the consensus statement is acute injury should be treated within 2 to 3 weeks following injury. The well-known Kennelly classification system is there, where we classify this injury into type A, B, C, depending upon which structure is damaged and how much external rotation along with varus relaxation we get. But the consensus statement is still there is no good classification system which totally differentiate which structure to be repaired and which structure is not damaged. So still in the future, we have to look for the proper classification. Conservative versus operative, grade 1 and grade 2, conservative treated gives a good result. However, grade 3, they always show poor functional outcome. Stannard and Levy, they have found that repair produce at around 30 to 40% failure compared to around 6 to 9% in reconstruction group. So consensus statement is repair of primary PLC is a valid treatment of bony avulsion and avoiding reconstruction of a structure that are not damaged. So we should reconstruct those structure only which are damaged and repair to be done to a secondary restraint like ITB, biceps and meniscocapsular tension. So there are well-known technique is one is fibula-based technique, Larson and modified Larson, and second is the tibiofibula-based technique where we, as described by Robert Laprade, where we reconstruct both LCL, popliteal tendon, and popliteal fibular ligament. So comparative study between these two, as done by Tremp and published in 2019, that they both techniques are equally effective, but neither the technique is able to restore the stability of the knee when combined PLC and proximal tibiofibular joint injury is present, which we are not discussing. There is no statistical significant difference in clinical outcome and stress radiography were observed between the two constructed group, as well as Jenny published in Knee Journal 2020. And what we found, as we rank all that if we do popliteal bypass like anatomical reconstruction, gives better and superior biomechanical property related to tibial external rotation stability compared to the Larson technique. However, the biomechanic study published in Arthroscopy Journal, it shows that the clinically relevant and under the clinically relevant dynamic force, both techniques provides equally good result. And the consensus statement on this is an anatomic posterolateral corner reconstruction is the preferred technique when all primary PLC structure are injured. So open versus all arthroscopic, all as arthroscopic still is a new child. In 2019, Jen Frings described that technique, but it has a long learning curve and the complication is still associated with it. When we see the complication of this procedure, it's a systematic review of 1700% having the PLC injury, and most of the most common complication is the surgery failure or residual PLC instability, and the second most common is the 16% cases is the arthropfibrosis. So these are the two main complications which we have to look for while we are repairing this structure or reconstructing this structure. Regarding the rehabilitation, when to start weight bearing protocol, the delayed and immediate weight bearing group experience a higher overall complication rate. So weight bearing is progressive. Weight bearing should be allowed. And regarding this, the consensus statement is sequential stage rehabilitation. First, range of motion, muscular endurance, then finally power. Early mobilization should be started from day one. Knee brace to be utilized at least 6 weeks. And functional assessment to be done before return to sports, such as running, cutting movement, and figure of 8 running should be performed. So to conclude, anatomic, biomechanic, and clinical knowledge of PLC injury still continue to progress. Finding the balance between recreating native anatomy and safely performing PLC reconstruction poses a big challenge, and the treatment decisions should be made on case-by-case basis.
Thank you, Amit. Very elaborative lecture. So we can take the question at the end of the session. Shwetab, are you ready with the lecture? So we can take up the Shwetab. He is going to present about repair versus reconstruction of posterolateral colon injuries. Shwetab, are you ready? You have to unmute yourself. Shwetab, unmute yourself.
Yeah, I'm ready. I'm just
In the meanwhile, Roshan sir, are you there? There's a question small. Roshan sir?
I'm there.
So in your pre-op workup, do you routinely get this alignment x-rays for this posterolateral colon injuries? Or it's only in chronic cases, not in acute cases?
Hello, I didn't get your question.
So in posterolateral colon injuries, Do you routinely get orthoscanogram or this alignment X-rays? You get this routinely?
In acute use, you mean to say
In acute scenario, do you get, or it's only in the chronic scenario do you get this?
acute
alignment
usually
X-rays?
you don't because the malalignment is never an issue in acute scenario. Acute is first is diagnosis. So I think the investigation of choice is MRI to see the other coexisting pathology like cartilage, the lateral collateral ligament, the lateral meniscus, the popliteus tendon, and the postlateral corner injury. So I think in acute scenario, the orthoscanogram or standing X-ray of both knees usually is not important. What could
And
be
what about
of
the stress
importance
X-rays?
is stress X-rays. Yes, stress X-rays usually I do the intra during just before surgery under anesthesia examination under C-arm or image intensifier. So that gives me an adequate idea of how much is the laxity as compared to the other leg. So you have to spend some 5 minutes. So the amount of laxity on the involved leg, and you can you can do that on the IITV rather than doing on a X-ray, because painful patient will not allow you for a stress X-ray, as it is difficult to get a stress X-ray in full situation acute injury.
But so that article of Laprad highlights that 4 millimeter difference. He does it in pre-operative scenario, a workup of the patient, and
that's true. But when you have an acute situation where you have a PLC injury, it's acute. Anybody who has PLC, you will realize the popliteal corner is a very high velocity injury, and usually patient is in great pain. So you may not be able to do this examination under patient is under anesthesia. He will not allow you to touch and do the stress X-ray unless patient is under anesthesia. So what was said and done, I usually in my practice, I do Oliver stress or examination under anesthesia with C-arm. So my basic diagnosis of instability is already in my clinical examination pre-operatively before anesthesia. So once I'm sure that the posterior corner is gone, there is a posterior laxity, there is a dial test which is positive, and there is a laxity on the hyperlaxity on the lateral side because of hyperextension, then I'm very sure it is a PLC and nothing else.
Dr. Nagaraj, are you there? You have any difference of opinion, or it's more or less same with you as well?
I think Dr. Roshan summed it up well. Your question was specific for acute scenario. So for acute scenario, whatever he mentioned, I totally agree with him. I also want to just point out that whenever we say grade 3 signs are seen, they are usually associated with the PCL. So when there is a grade 3 sign, we know that the lateral collateral ligament and the popliteus and the popliteofibular is involved. So stress X-rays, frankly, in a grade 3 acute scenario would not be necessary.
Okay. Thank you. Shweta, are you ready? Can we shift to your
I'm
talk?
ready. I'm ready.
Great. Thank you, Doctor.
Good evening, everyone, and thanks to AUP for this opportunity. So Dr. Amit has already thrown a lot of light on the surgical management also, and I have to discuss on the surgical management of PLC injury, repairs versus reconstruction. So I'll start. I'll try to there are so many procedures which have been described and named, and there's a lot of confusion. And so I'll just try to throw light on this particular problem that we have already in such a way that we have already diagnosed the grading of the injury, the timing of the injury, and then how do we go about treating these patients. So posterolateral corner is the primary restraint to the varus stress to the knee and the external rotation of the tibia, and it gives the secondary restraint to the posterior translation as well as the anterior translation of the tibia. Now it has been described to be composed of a lot of study has been done over the past few decades, and in the current scenario it is supposed to be composed of primary stabilizers, which are 3, that is the lateral collateral ligament or the fibular collateral ligament, the popliteus tendon, and the popliteofibular ligament. Various biomechanical studies have shown that these are the primary stabilizers, and there are secondary stabilizers such as the iliotibial band, biceps femoris, lateral capsule, coronary ligament, arcuate ligament, and fabulofibular ligament. So that is the repair, the reconstruction, and the osteotomy. So when do we go for a repair of the PLC injury? Hello, am I audible?
We can hear you, Shweta. Yeah, you are audible.
Okay, I'm sorry. So if we look at the repair techniques of the PLC injuries, traditionally they have been seen to be having higher failure rate as compared to the reconstructions. And as Dr. Amit had already mentioned, almost 40% failure rates or 37% failure rates have been shown in different studies by Levy et al. And Standard et al. So the repair of the PLC, the current consensus is that it is indicated in the acute injuries of the posterolateral corner, and that should be done preferably within 2 weeks and not more than 4 weeks, because by the end of 3 weeks the differentiation between various structures becomes very difficult, and it is very difficult to reattach these structures back to their native position. So when a repair of PLC should be done, it has been shown that avulsion of structures which have been torn off from fibular head, like the LCL, PFL, and the biceps, the lateral capsular avulsion, and meniscal capsular avulsion. These are the injuries which can be repaired in the acute scenario to give very good results. In the acute scenario, the mid-substance tears are not good for repair, and if the repair is to be done, it should be augmented or a primary reconstruction of these structures should be done. McCarthy et al. Has reported that the repair of distal-based avulsions with adequate tissue quality have results which are equivalent to reconstruction, and recently Weisman et al. Have also shown that a early repair with an associated concomitant ACL reconstruction have results which are as good as those of reconstruction of posterolateral corner. Now, some of the techniques of repair of posterolateral corner injuries in the are the en-masse repair technique, which was described by the Shelbourne, in which now this technique, he has said that it has to be done preferably before 4 weeks, and instead of dissecting the various soft tissues, the en-masse healing tissue is reattached to the tibia, as shown in this particular figure, that the entire tissue per se is reattached to the tibia. And it has been shown that the reattachment of the capsule to the tibia, it gives a very good strength to the repair. And secondly, what repair we can do in the posterolateral corner injury are the reattachment of the bony avulsions, as shown in this particular side, that the biceps, the combined structures, they are being reattached to the fibular head using transosseous suturing. Now, coming on to the reconstruction management of the PLC. Now, for the reconstruction of the posterolateral corner, the timing is ideal timing should be between 3 to 6 weeks from the injury. And by that time, the knee should have good and painless range of movement. Laprade has said that if the injury is more than 6 weeks, we have to look at the limb alignment and look for the varus limb alignment. And if there is a varus limb alignment, we should always consider the patient for osteotomy, because osteotomy, if there is significant, not for the minimal varus, but for significant varus like a double or a triple varus, because osteotomy in such patients may obviate PLC reconstruction in up to 38% of the cases. So once again, we look at the posterolateral corner. These are the primary stabilizers as shown in this slide. This is the FCL, this is the popliteus, and this is the PFL. And in the reconstruction, we need to know the exact sites of attachments of these ligaments, and we need to create all these ligaments. Now, on the basis of what all structures are being reconstructed in the surgery, the PLC reconstruction has been divided into non-anatomic techniques and the anatomic techniques. Now, the non-anatomic techniques are basically fibula-based techniques, and these non-anatomic non-anatomic techniques, not all primary stabilizers are reconstructed as shown in this diagram. There is a single femoral socket and then there is a single fibular tunnel, and only the LCL has been reconstructed. Then another fibula based non-anatomic technique is one in which was described by told by the doctor, mentioned by Dr. Amit as the RCRO, in which there are two sockets for the femoral and there is a single socket in the fibular tunnel. Now, by using a fixation in the fibular tunnel, we can reconstruct the LCL as shown here and the FPL as shown in this case. But all these techniques are non-fibular, non-anatomic, and they are fibula based. For a technique to be anatomic, it has to be tibia based, because in order to reconstruct all the three structures, we need to have a tunnel in the tibia as shown here. And in these anatomic reconstructions, which have been described by Laprade as well as Franciosi et al., we have two femoral tunnels which are at the origin of the LCL and the popliteus tendon. We have a fibular tunnel, and then we have a tibial tunnel also, by means of which we reconstruct the popliteus, and the popliteofibular ligament is reconstructed from the back of the fibula to the back of the tibia. Now, what are the indications of anatomic and non-anatomic reconstruction? So, in the case of knee, which is hyperextended, if there is an external rotation recurvatum type of deformity, if there is an associated PCL injury, a proximal tibiofibular instability is there, and if you look at the grading, the grade 3 type of PLC injuries or a grade 2 with an associated cruciate ligament injuries are the indications for an anatomic reconstruction. However, in case of subtle instabilities where there is a pure rotational instability or a pure varus deformity, then we can go ahead with a non-anatomic fibular based reconstruction. Coming on to the post-op rehab, the rehab is is the usual kind of rehab. Like, we have to give knee brace for 6 weeks and non-weight bearing emulation for the same time. And initial 2 weeks, we have to try to restore the tibiofemoral and the patellofemoral ROM. And after 2 weeks, full ROM as tolerated is attempted, and weight bearing as tolerated started from 6 weeks. A thing to note down is that isolated hamstring strengthening is limited to avoid stress on reconstruction until a minimum of 4 post-operative months, and at approximately 6 to 9 months after surgery, return to sports may be started. So, just to show you a case scenario, this is a case of a 30-year-old male who fell into in a drain, and he presented around 6 months after the injury with pain and instability. There was a mild varus, the Lachman was negative, the posterior drawer was positive, the dial test and varus stress were positive. On the alignment X-ray, there was a mild varus, but it was not very significant. These are the MR pictures, and and I do the stress X-ray intraop. It showed there a significant opening on the lateral side. This is the dial test on the normal side, which is being done, and on the left side, the injured side, which is significantly more, and this is the demonstration of the instability. So after the so this patient was having a combined PCL as well as the PLC injuries, and after performing the arthroscopic PCL reconstruction, the PLC reconstruction was done with a lateral hockey stick incision. The first step is to do a thorough neurolysis of the common peroneal nerve, and it extending up to the lateral compartments, so that compartment syndrome kind of thing might not develop. Once the nerve is secured, then we move to the fibular head to try to find out the FCL attachment. It gives us an idea of where we have to go for the on the femoral, it gives an identification of the femoral attachment of the FCL. Next, we make the tibial tunnel, which is just medial to the, it's the flat spot just medial to the Gerdy's tubercle. Now this tunnel, I try to make it manually because in order to avoid any injury to the vascular structure. And once the tunnel is made, the loop is passed through it. Next, we make the fibular tunnel, which is started from the anterolaterally to the posteromedially. This is made with a 4.5 mm reamer. In our scenario, because we are not using allograft, so we can manage with thinner tunnels. Next, the LCL and the popliteus femoral sockets are drilled. The LCL, the popliteus socket is around 2 centimeter anterior to the FCL socket, and the grafts are passed one by one. After the fixation of the graft has been done in the femoral socket with interference screw, we pass on the LCL tunnel, the LCL graft underneath the ITB from the anterior part of the fibula to the back of the fibula. And next we do the same with the popliteus tendon. And then we pass on both of the grafts anteriorly out of the tibial tunnel. Once that has been done, I've done the fixation of the LCL, and then in around 30 degree of flexion with neutral rotation and slight valgus, we fix the LCL first in the fibular tunnel. Once that has been done, in around 70 to 90 degree of flexion, the tibial screw is placed, thereby completing the anatomical posterolateral corner reconstruction. And demonstrating a satisfactory stability. These are the post-op X-rays, and this is the final result. So thanks for your attention.
Thank you, Shweta. A wonderful demonstration of surgical tactics and technique. We will take question after the session. Neeraj, are you ready with your talk?
Yeah, I'm ready.
Neeraj? Okay. So you can share the screen. Shweta, there is a question.
Stop sharing.
Shweta?
Yes, sir.
So is there any difference in rehab protocol in repair versus reconstruction scenario? You go slow in repair, or it's the same rehab process that you follow in reconstruction?
Actually, the previous understanding was that the repair used to be in the repair scenario, the rehab used to be slower. But in the current scenario, when the repair has been done timely with good tissues within 3 weeks, we follow the same rehab protocol as in the case of a reconstruction. One thing I would like to add up here, that if there is a concomitant cruciate ligament injury, it should be reconstructed in the same sitting with the repair of the posterolateral corner, because that leads to the centralization of the pivot and it leads to a better healing of the posterolateral corner injury. If we do it in 2 stages, then it is said that the healing of the posterolateral corner might not be that good, because of the incongruity of the surface of the femoral condyle and the tibial condyle. Both are convex. So centralization of pivot is important.
Roshan sir? Hello, Dr. Roshan?
Yes, I can hear.
What's your indication about doing a repair in PLC scenario, non-avulsion scenario? When do you think of doing a repair for PLC injuries, acute PLC injuries?
See, if patient is coming to me very acutely on the, say, day 1, day 10, I will consider a repair. If I see it is avulsion on either tibial side or a femoral side.
So voice is very less, sir. You have to be loud.
Hello, can you hear me
Yeah.
now? Can you hear me now?
Yeah.
So in acute scenario, if it is a avulsion from femoral side and tibial side, then I always plan for a repair, because that is a very good result. wherever we see, I see a mid substance pair of PLC, the lateral collateral, the population ligament. In those situations, it's better to do an additional reconstruction, even if you are able to repair end to end, because the failure rates are very high, as been said in previous talks about the reconstruction and repair. So acute
Dr.
injuries.
Nagaraj.
I just want to add here that last couple of years, and there's a lot of review of literature also on this, that if you have a patient who's having a multi-ligament scenario, typically these patients have a multi-ligament scenario, ACL, PCL posterolateral corner, or a PCL posterolateral corner. So when we know that the posterolateral corner repairs, and we are not talking about the osseous avulsion, we are talking about the posterolateral structures getting damaged. We know that they will never do well with isolated repair. You will always reconstruct. You would always add an augment because the failure rate of isolated repair is very high. So a staged procedure for me is not an option anymore. I try to do everything in one single setting. So if it's a PCL, PLC, I like to go in the subacute stage. Usually by that time, the structures are not very identifiable. So do a formal reconstruction on the lateral side, you do a formal reconstruction of the central pivot, and if ACL, PCL, PLC is there, all together in one sitting. The patient is much more compliant in rehab, much more back to action much earlier than in a staged procedure. So this has been my protocol, except for the osseous avulsions. If it's an osseous avulsion, you can be confident of doing a staged repair because there can be a good healing.
Yeah. Shweta, in the scenario of ACL plus PLC and you're planning a PLC reconstruction with an ACL, would you like to go for 2-tunnel technique? Because there will be 3 tunnels then, ACL tunnel versus 2-tunnel popliteus and fibula. And then do you go with single tunnel for PLC and then 1 tunnel for ACL, or you still go with 3 tunnels in a scenario of PLC reconstruction as well as ACL?
So if we angle our tunnel for the actually I'll just base it on the basis of the kind of injury if I have. So if it is a pure rotational or pure varus opening kind of scenario, then I will go for a non-anatomic kind of reconstruction or a single, but if or a single femoral tunnel, which is in between the two popliteal and the FCL sockets. But if it is a full-blown PLC injury, then I will try to change the direction of my tunnels proximally and anteriorly, and around 30 degrees for the popliteal tunnel, and around 20 to 30 degrees for the FCL tunnel, both in anteriorly as well as proximal, and in that way I can protect my the ACL tunnels and the posterolateral tunnels from getting confluence.
Nagaraj, you would like to add something into this? In a scenario of PLC reconstruction and ACL reconstruction?
So first of all, let the audience know that this combination is not so common. So ACL with posterolateral corner combination is not very common, that too grade 3 posterolateral corner. Having said that, whenever we encounter this, for me, the Leprard total anatomic reconstruction is reserved for chronic cases. So when I see a chronic grade 3 posterolateral corner with varus opening, significant varus opening, I reserve the anatomic reconstruction techniques. I like to go for the simple fibula-based techniques for the cases where there is a posterolateral corner with ACL. I don't mind doing even the RCRO technique, because then you don't have to go through the tibia, and you can finish off all the graft from the same limb. You don't need to touch the other limb. So single semitendinosus is enough for doing your anatomic reconstruction, and your quad tendon or your bone tendon bone can be useful for your ACL. However, if you want to do the anatomic techniques, then you need to use 2 grafts and probably use the other side also. So therefore, to answer your question, ACL with PLC, I would do the fibula-based techniques, not the Leprard technique.
Thank you. Neeraj, are you ready? Roshan, was you want to add something?
Yeah, I just wanted to add on that.
You have to be loud, sir. Yeah, your voice is very, very less. You have to be loud.
Yeah,
A
can
very
you hear me
feeble
now?
voice.
Can you hear me now?
Yes, sir.
Yes. So, when you are seeing the PCL with PLC, you will see a more of rotatory instability. The rotational instability will be very, very high. When you are seeing a ACL with PLC, your rotatory instability is not that significant. And as Nagaraja directly said and already said that you will never see a grade 3 ACL with grade 3 PLC. So usually what you see is grade 2 PLC and ACL. So in those situations, it's better to do a single tunnel, femoral tunnel ACL reconstruction and single tunnel PLC reconstruction. Because my philosophy is very simple. PLC otherwise also has got very high failure rate. Hello. Even if
Yes,
even if you do a very good reconstruction of PLC, it has got very high failure rate. So why make additional tunnels on the femoral side when you know that this is going to fail?
So you recommend only single femoral
Yes,
tunnel?
yes. So it is always advisable. And when you are doing PCL with PLC, always do a double Laprade type of reconstruction, because when you have a PCL with PLC, it is excessively unstable. It is lax in hyperextension. There is a hyperextension instability. There is a reverse pivot which is positive. And those situations, it is advisable to do a PCL. Maybe you can do a single bundle or double bundle PCL depending on your expertise. But PLC has to be a Laprade type because you need a very stable lateral side. So my indication for ACL with PLC is one tunnel, PCL with PLC, a two tunnel PLC reconstruction.
Roshan boss, you
Yes.
are dealing quite a good amount of sports population. Do you
Okay.
feel any stiffness of the knee in case of Laprade reconstruction, wherein you make knee very tight kind of? So any restriction of internal rotation that
See,
you see with sports
usually
population?
I will tell you, Vinay, these are all career-ending injuries. It never happened that after PLC the patient has gone back to his previous level of sports. I've been seeing a lot of mixed martial art patients, some of the kushti patient, the wrestler, and none of them have ever gone back to their pre-injury status. Even if you do whatever kind of, see, MCL is completely different. MCL is a different volume. PLC is a different volume. Whole knee is hanging on PLC. So the moment you have a failed PLC, that patient is not going to be able to walk. So in my opinion, more emphasis should be done on the PCL with PLC with two tunnel technique rather than ACL with PLC. And stiffness is part and parcel of the game. Yes, they may not be able to go back to their pre-injury status, but the stability is more important than the
Thank you. Thank you, sir. Thank you so much. Neeraj, are you ready?
Yeah, I'm ready. My skin is
Yeah,
visible.
start. Yeah, start.
Yeah. So I'll be talking on failed PLC injuries. So actually, as we are growing more and more, so we are seeing more and more PLC injuries being done. Initially, we were seeing only cruciates being done, but nowadays with so many new diagnostic modalities, we are not missing our PLCs and we are doing it. So we are seeing more and more failed PLC injuries also. So slide. Yeah. So why PLC fails? So I've just made 4 points. So one is neglected. So not given enough importance in a multi-ligament injuries. Second is a failed fixation, which we have discussed enough in the previous talks. Third one is non-anatomical procedures, which usually fails. Even that we have discussed enough. And fourth one is the malalignment, which we'll discuss mainly in this talk. So missed or neglected PLC injuries. So concomitant injuries are always seen with the PLC injuries. And even the patient comes with a thought in the mind that he has got an ACL injury or PCL injury. So he must get the cruciates get operated, and he gets operated, the cruciates and the PLC is missed. Or the PLC is done, but the PCL is not addressed. So the knee is not centered and the PLC fails. So missed and neglected PLC injuries are very common. Like we see a small chip avulsion of the fibula in the X-ray, and somebody puts a plaster that this will heal, or a small fibula avulsion here, and the surgeon thinks that it is in the contact. So like any other trauma case, it will heal. And the moment patient starts weight bearing after 6 weeks or 2 months, this starts opening up and the patient starts having a varus thrust and it fails. So as Roshan sir said, PLC is totally a different ball game. It is not as forgiving as MCL. You put a plaster, you just give a brace. MCL most of the time heals, but PLC pivot in which the whole knee is hanging. So PLC is not forgiving. So you have to get it operated. If the PLC is injured, you have to get it operated in acute setting, preferably in less than 2 to 3 weeks. Failure of repairs. So there are high failure rates of repairs, as it was discussed with Dr. Amit also. The Levy has showed in 2010 that failure rates are as much as 38% as compared to more comprehensive reconstructions. So repairs should be reserved for the acute bony avulsions. Acute means less than 2 weeks. If you can see a fibular avulsion, then you should repair. Otherwise, you should go for reconstruction. Even in cases of fibular avulsion, if you have concomitant PCL injuries, then you have to decide on table, and then you should decide that you should go for a primary reconstruction. Then non-anatomical reconstruction. As the Larson procedure, which was discussed before, it has a high failure rate. So even if you see the paper of Robert Laprade in 2016, he has mentioned that commonest cause of failure is a non-anatomical reconstruction in PLC injuries. So whenever in doubt, you must go for total anatomical reconstructions. Yes, it's in the cases of ACL injuries concomitant, you are sure that it is not a high-grade injury and rotational instability is not there, the hyperextension is not there. So you can go for a single tunnel based reconstruction as described by Larson's. But if you have a concomitant PCL injuries, then better to go for a Laprade type anatomical reconstruction. So initially we thought that doing a Laprade anatomical PCL reconstruction will actually make the knee stable, and we have near anatomical reconstruction. So we'll have a near pre-injury status and the repair will not fail. But it is not so. I'll just show some cases. There was a patient who had got a fibular avulsion and concomitant PCL injury. So initially only the fibular avulsion was fixed by some surgeon. I don't have the post-op X-rays because it was never clicked, but as per the patient, the fixation was done. And once the patient, and PCL was not touched. So once the patient started weight bearing, it failed after almost 2 to 3 months of the surgery. The patient started having hyperextension and varus thrust. So he went to another surgeon, and this time PCL was also addressed and Laprade anatomical fixation was done. The patient was put into a brace and slowly he started weight bearing. So after 3 months, it failed again. So what went wrong? Now it comes to the alignment issue, what we were discussing initially after the first talk. So malalignment is a major cause of failure in a well-done PLC reconstruction, which was shown by Arthur et al. In 2010. And he has also showed that if you correct the malalignment, then many of the times the PLC reconstruction is not needed in such patients. So in this patient, we had got a standing scanogram, and this showed a varus malalignment. Actually, it was on both the sides, but this side was more because of the PLC injury. This was the PCL reconstruction screw, and actually on clinical examination, there was grade 3 PLC and there was posterior door positive and hyperextension was there. So this is the video of that patient. So you can see how much opening was there. Almost 30 degrees of varus opening was there under anesthesia, and there was grade 3 posterior door test positive. So now we had planned for medial open mesh STO with slope change, because PCL reconstruction was already done, which had failed, and anatomical Laprade reconstruction was done, which had failed. So as we note, if we change the slope, even the posterior laxity is gone, because we know that the medial tibial plateau is triangular in shape and the angle with the posterior cortex is 45 degree plus minus 6, whereas the lateral tibial plateau has an angle of 90 degrees. So if we open up the osteotomy medially, the posterior slope increases. So it will take the tibia forward and the PCL laxity is gone. So we just took advantage of this and we planned for a medial open wedge osteotomy with an increase in posterior slope. So this was done for this patient. And after this procedure, the knee was stable.
Yes.
You can see.
Yes.
Yeah.
Your slides are not moving, I think.
Huh?
I think your slides are not moving.
Okay, it is moving on my side.
It is moving. It is moving. I can see that.
Yeah,
Okay.
maybe others can see it. Hello.
It is
I can
moving,
see.
go
Yeah,
on.
I can see it. It's moving.
It is moving,
I
right?
saw that.
Okay, okay. Maybe Vinay has something to do with your connection. Okay. So after doing the STO, there was no malalignment and there was no varus thirst, and the posterior draw was also negative. So we decided to leave this patient with an STO alone. So another case is there in which there was ACL and fibula avulsion, PLC injury. You can see he underwent ACL reconstruction, and along with that, there was some kind of PLC or LCL reconstruction. Details were not known, but I think this was a tibia based reconstruction because screws are used, and this fibula was not touched in the reconstruction. So in clinical examination, the ACL was working, but the patient had again varus thrust, almost 30 degrees of opening was there. In this, we could not get a standing scanogram, but when we got an X-ray, the long leg X-ray standing, we could see that both the knees were in varus, and he had some kind of tibia vara also. So this also we decided to do a medial open wedge STO. Since there was no PCL injury, the posterior draw was negative. So we just decided to do a routine middle wedge open without a slope change. And this was done. But even after, in this patient, even after doing the STO, there was varus opening, which was little lesser than the before, but there was a varus opening. So we did a Larson's procedure on the lateral side. And after that, the knee was stable. So this is after putting the plate and doing Larson procedure on the lateral side. So with this, whatever is there, but if you see a chronic failed PLC, and even in the acute setting, if I see a patient with a varus malalignment of the knee, I go for a scanogram, because whatever reconstruction procedure, whatever is strong Laprade or whatever strong procedure I do, if there is malalignment, once the patient starts bearing weight, it will definitely open up slowly. So it is always better to check alignment, because clinically we can see in all our patients that how is the alignment of the knee. If in doubt, we should go for a scanogram. Thank you. Dr. Vinay?
Yes, Dr. Neeraj.
Yeah.
That was a wonderful talk and take. I think we can invite the questions for the last session, for the last talk. Dr.
Yeah,
Vinay, are you there?
This was the last talk. I think Dr. Vinay's connection is having some problem.
Oh, yes,
So
no problem. We'll move on.
we can go to Dr. Roshan and Dr.
Dr.
Nagar,
Shetty and Dr. Roshan.
and they can give their inputs on failed and chronic PLC injuries. What should be the protocol? Roshan sir, can you hear me?
Yeah, I can hear you. I can hear you.
Yeah,
See,
please give
the-
inputs on this.
Yeah, any takes on the talk?
Yeah, it was really a great talk. You know, the way you demonstrated the management of failed PLC reconstruction was really great. And I think the malalignment correction remains the mainstay in the management of PLC injury. And even if there is no malalignment, and in such cases, just doing reconstruction may not work. You know? So the moment you see a PLC which has failed, it is had to be associated. In fact, one of the case you have not done a scanogram or orthoscanogram.
I could not guess, sir.
Yeah, in those cases, it is very important to have the assessment of malalignment, unless you know what exactly is amount of assessment, and especially in PLC, when you cross that Fujisawa's point and excessive valvulization, that is at least 5 degrees of excess valgus, then your requirement for PLC, strain on PLC reduces pretty drastically.
Yeah.
So I think the high tibial osteotomy remains a very
दो
important.
पेज खाली एक का दो कॉपी पीछे वाला नहीं.
Okay, sir. But sir, still I have seen in many cases, even after excessive valgization, we do need some kind of procedure on the lateral side. and in some cases we don't need.
So in those cases, I think it is a rotary instability rather than the valgus. So
Okay.
usually we tend to check only valgus. So probably it's a rotary instability which requires some kind of attention. And by just doing a sling procedure, also you can get adequate stability.
Yeah, and like in last case, which I
Yeah.
showed, the last one, I just added a Larsen procedure and it was stable.
Stable. Yeah.
But
So
in
I
the
thought-
previous, which I showed, which had more, maybe the slope was changed because of the PCL. So it got stabilized beautifully because
Yes.
the instability was more in the first case. But only with the STO, it got stabilized. While in the second case, I had to do a concomitant procedure also.
May I ask a question?
Yes,
Yeah.
please.
Sir, what is your criteria for a primary osteotomy in a case of chronic PLC? What is the exact, is there some exact value or malalignment on the basis of which you go for a primary osteotomy?
See, usually I will any malalignment more than 5-degree varus is a malalignment. It is a significant malalignment. Will need some kind of correction. And once you cross that 5-degree varus to 9-degree varus, it is not it excessively stress on your PLC. So the moment you have more than 5-degree varus, there is just constant stress on PLC. So in such situation, it is very important to correct your varus. Unless you correct the varus, you will not get the less stress on PLC. So the requirement of lateral structure is very, very important when you don't correct that malalignment. So,
I'll just add, sorry.
Yes, Nagaraj, please go.
I'll just add one thing. Dr. Roshan has covered about the coronal malalignment. You should also do a very dynamic assessment. So the varus thrust and recurvatum, the triple varus which we talk about. So clinically, if you see a varus thrust, that means there is a dynamic lateral instability now. So the lateral structures, if you do only a reconstruction, they are bound to fail. So coronal malalignment more than 5-degree, as Dr. Roshan mentioned, clinical assessment of dynamic varus, and definitely for the ones who have got a recurvatum and a triple varus. These are the diagnostic criterion where you can do a primary osteotomy. And usually these patients, like Dr. Roshan mentioned, will not be happy with the rotational component. So you might need to add a reconstruction. The only tip I'd like to add is these cases sometimes are the missed fibular avulsion fractures, as Dr. Just showed. So for these cases, you need to be very clear in dissecting the peroneal nerve. You need to go all the way, incise the peroneal fascia, dissect it, mobilize the nerve, and you'll have to drill a tunnel right under that fragment, which you can manage almost always. So you need to be prepared to do that additional procedures also along with your malalignment surgery.
So, sir, one question I would like to ask: when you would go for primary osteotomy, you see a fresh case, see a fresh case of PLC, and there is a varus alignment, malalignment. So you would go for primary osteotomy and then fixation of that, or you will just fix it if you got a fibular avulsion.
So fibular avulsion is, now we are talking about a patient who's got a constitutional varus. So it's going to be symmetrical bilateral constitutional varus. So these are the patients who are born with it. It is normal for them.
Okay.
And there has been an acute injury and on which there is a good chance of healing because it's a bony avulsion. So you would not consider osteotomy. Osteotomy is for a patient who is now gone into the chronic phase and who is now developing the dynamic instability component along with the recurvatum. This is typically for those category patients, and usually this is the PLC which has become chronic. So the deformity on the affected side is much more than the normal side.
And one more scenario: if you have similar injury, similar varus, but the injury is in soft tissue, mid-substance PLC, then also you'll go for same thing, like you are not having a bony avulsion this time.
Correct. So that's a great question actually. So just like whenever, for example, you have a varus knee with an ACL.
Yeah.
So if you have a patient who now has come with a posterolateral corner, I think the chances of him failing are very, very high. So you would rely on your coronal malalignment. If it's on the really higher side, is MPTA is around 80, 81. So deformity is in the range of 9 degree, 10 degree. You know your reconstruction is going to stretch out. So those categories, definitely you would consider osteotomy primarily. And of course, you would like to reserve this for the severely malaligned patients. So the borderline patients of 4-degree, 5-degree constitutional virus, again, there you would do a reconstruction. You would rely on probably a stronger reconstruction procedure for such a patient because the chances of stretching out are very high. So you would not do a simple Larson's technique. You would probably consider to do a Laprade type of
Laprade. One more question. Like if you see an acute PLC injury, so getting a standing scanogram, full weight bearing is very difficult. Like in chronic, we can get it.
True.
So how do we proceed? How do we actually see the axis? Because acute injury, you cannot ask the patient to have a full weight bearing standing scanogram.
I think the take home message is acute scenario, you should not be thinking in terms of osteotomy.
Okay.
Osteotomy is for the chronic scenario.
Chronic only.
Malalignment.
Niraj,
Yeah.
do you know what is the Mortal Kombat where the martial art people hit the opponent so that he is down? It is always on lateral collateral ligament.
Yes.
The moment you hit somebody's lateral collateral ligament, he will not be able to stand. So
That's what I am asking.
So don't ever try to make your patient
He
stand.
cannot, sir. That's what he cannot even put.
He will curse you whole life. So PLC is the most important structure of the knee joint. It is not the medial collateral ligament. One
Yes,
can
sir.
see in fact during doing osteotomies, the open wedge or medial open wedge osteotomies, we remove the MCL,
Yes.
but you can't remove the PLC. You know, so PLC is a very, very important structure. The one structure through which your knee hangs or complete weight bearing happens of the knee joint. Biomechanically, most important structure is PLC. And the moment you have damage to PLC, just can't imagine a patient unable to walk or he has been forced to walk and say you want to do an orthogram. So I think that is completely unindicated unless he has less pain or he is able to manage his pain. It should not. And acute situation, it is not needed, as Nagaraj has rightly said. It's not needed. It is only in the chronic situation when you are planning a reconstruction or maybe at some point you are planning for a osteotomy. That time you have to have an orthoscanogram.
And same way, if we have valgus malalignment, so it is beneficial for our reconstruction. Maybe we can be little generous with it.
Valgus, what is it?
If many females we see with valgus malalignment, valgus knees. So lateral collateral injuries in valgus knees should be more rewarding for us. We can be little.
Usually they won't present with your symptoms. You know, the lateral collateral ligament with the valgus knee, they will not present with that instability. They will present with medial instability.
Yeah.
So biomechanically, it's a completely different prospect. You know.
Okay, sir.
Okay, that has been a wonderful talk and session. That was very unclear.
Who's that?
I think from the Ortho TV.
Yeah, Ortho TV.
अरे पैसा मांगो उनसे Ortho TV से पैसा. 1 hour honorarium. Niraj, if you're listening me, send me a check.
Sir, it's not from Ortho TV.
अच्छा, कौन है फिर?
कहीं और announcement हुई मतलब सर.
अच्छा, रेलवे स्टेशन पे कोई बैठा है क्या?
Maybe. Vinay boss कहाँ चलेंगे? Maybe his connection has distant.
Dr. Vinay here has some problem.
Yeah, something
with the connection, I guess. No?
Yeah.
अरे आशीष.
Dr. Ashish.
President sir,
Ashish sir has not said anything.
Dr. Ashish is there. Dr. Ashish.
I could see Ashish. Ashish?
He is there, but he's frozen.
I'm very much here.
सर कुछ बोलिए सर.
कुछ शब्द सर. Okay, anyway, I think since there's lot of connectivity issues, I'll take the is Dr. R.P. Gupta sir there? He's also.
I think Ashish sir is saying something, but he is muted.
कौन म्यूट किया आशीष को? प्रेसिडेंट है भाई.
Okay. No, it's something like president.
अच्छा, now we can hear him.
I was just listening, but I was in another CME.
बाप रे.
That's why.
This is called multitasking.
नहीं बहुत बढ़िया प्रेजेंटेशन था डॉक्टर शेट्टी एंड यू आर इनलाइटनिंग अस विद अ
अरे बस क्या है यार।
अरे बस की क्या बात है, वाकई बढ़िया था। बहुत सारी चीज तो रोज सीखने को मिलती है ना, करने को कम मिलती है।
Okay.
चलिए, और क्या, ऑल गुड।
I think we are on live. So जो भी बोल रहे हैं हम सब live आ रहे हैं। You
कुछ
should
ऐसा नहीं बोल
request
रहे।
Ortho TV को बोलो भाई जो live
Okay,
बंद
sir,
करो।
I think since we have had a rich and fruitful session of interaction and questions, we come to the end of the proceedings. I must take this opportunity since Dr. Vinay is not around, he's not able to connect back. I'll take this opportunity to thank Ortho TV, to thank our panelists, Dr. Roshan Wade, Dr. Nagraj Shetty, our president, Dr. Ashish Kumar, secretary, Dr. Vinay Pandey, and the faculty, Dr. Neeraj Srivastava, Dr. Shwetab Rai, Dr. Amit Jha, for being there and for giving us this valuable time, a lot of insight into this very difficult corner of the knee. And thank you once again, everybody. And I think we'll call it a day. And we still have fond memories of the UP Orthocon. Thank you so much, sir.
Thank you.
Thank you.
Thank you, Dr. Kamraj. Thank you.
Thank you
Yeah.
everyone.
Bye, Roshan sir. Bye, Ashish
Thank you.
sir.
Thank you everyone. Bye.
Okay, goodbye,
Good
sir.
night, everyone.
Good
Bye-bye.
night, everyone. Bye-bye.
Now, how do we go off? Ortho TV, yeah, we are concluded.